Good evening, everyone. Welcome to this webinar entitled Musculoskeletal Ultrasound Assessment of Tendinopathy, presented by Greg Fritz and Dr. Colin Rigney. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to evaluate the microstructure and design qualities of tendon fibers, understand the effects of overload on tendons and their fibrillar matrix, learn the spectrum and continuum of tendinopathy, understand the process of musculoskeletal ultrasound tendon scanning, and recognize the sonographic signature of tendinopathy within tendons through case studies. As an ACCME accredited provider, it is the AIUM's policy to ensure that the content and quality of this activity is balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Greg Fritz, Colin Rigney, and Darcy Belito de Luna have no disclosures. At the conclusion of this webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During tonight's presentation, if you have questions for the presenters, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenters will not begin answering until the end of the presentation, at which time they will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to present Greg Fritz and Dr. Colin Rigney.
Thank you, Darcy. And I want to welcome all of the participants out there for this afternoon, evening webinar. I know this is a special time and your time is valuable, and I want to thank you for being part of this tendinopathy webinar. I want to thank the AIUM and the APTA for this opportunity to platform the musculoskeletal imaging of tendinopathy. And I also want to especially thank my colleague, Dr. Colin Rigney, for his willingness to put together some real-life case studies that will be the meat and potatoes of tonight's webinar. Using that analogy, I have to admit that I'm feeling like the pre-meal salad, and that I'm going to be getting into some of the green leafy vegetables of tendons. But as I do, I'm convinced that you're going to find some of the magic in what they can do. And so I will just get right into it. Darcy has already gone over the majority of these objectives, but the bottom line is I want to spend some time talking to you about the microstructure of the tendons and some of the important values that they have, as well as some of the pathologies that can develop out of that. And then I want to have a period of time to spend on some of the pearls that I have used in my practice, which does bring up the fact that my name is Greg Fritz, and I'm a practicing physical therapy clinician in the Northwest of Northwest Washington. I have utilized imaging ultrasound in my practice for about 11 years, and I am thrilled at the turnout of my own profession in the review of this webinar, and I look forward to showing that to you. I want to spend some time going over some of the anatomy for those that aren't as familiar with it. Tendons are that long strand collagen structure that joins the motor muscle to the anchor bone, and it's involved in transferring the power that comes from the muscle to move the joint across that barrier with the bone. And I want to show you that there are some tendons that are of smaller profile and tendons that are of longer profile here as the Achilles tendon inserts into the calcaneus. And I want to show you that primarily in the heel cord or the Achilles tendon, there is a tension that we're working with, whereas over here on the peroneal tendons, there is also some compression. But I want to call out that tendons, again, are from muscle to bone, while ligaments are the same long strand collagen from bone to bone, here as in the inguinal ligament, here the calcaneofibrillar ligament, and the anterior talofibular ligament. And continuing on with collagen fibers, the fascia and aponeurosa is where we connect soft tissue to soft tissue. However, wherever they appear, the long strand collagen matrix is composed principally of collagen type 1 fibers. That's the parallel fibers that you can see revealed here in this particular call out. And the importance of this is that we're dealing with tensile strength, and where type 1 collagen is a fibrillar structure that is a very dense hair-like structure, a type 3 collagen is a mishmash, and type 3 collagen is called out to do repair work in tendons where there is lesions, and where they show up, they don't have the tensile strength that the parallel fibers from the type 1 collagen do have. As you take a look at tendons on ultrasound imaging, and you go from the bony connection to the muscle connection, you will see that they appear in a linear fashion and showing lines of echotexture. If you can take a look at this particular cable and think of it as a longitudinal view, that's what we would call an LAX view, as opposed to the orthogonal or 90-degree variance where we've sliced through the tendon. This is a tomographic representation of the inside of the tendon, and when we slice through a living tendon, we're actually able to see each individual fiber in their short axis presentation. I'm going to try to actually put some real life pictures here for you. This is my wife's heel cord tendon. You can see the orientation of the probe down here in the bottom left, and you can see that there's fiber texture that we can call out from the beam directly across the heel cord. This is the calcaneus bone, and the periosteal echoes there is there. This is an actual representation in this black envelope as to the orientation of the long axis view. And this little slice, this little red slice line, is the actual short axis view that you're seeing here, with looking down the actual fibers of the heel cord. I want you to go with me deep into those fibers, and I want to have us look at an electron microscope visualizing the short axis fibers of the collagen type 1. You can start to see the fibrillar structure closely packed, and this enlarged call out starts to bring into view the fibrils that make up the fiber. And even larger off to the right here, you can see a single fibril and the serrations that occur in the fibril, the first sign of the crimp that we use for energy storage. This purple line here, I want to have you keep this particular fibril in mind as we go to the schematic drawing right here. This is that fibril on the previous image, and I want to call out to you the first in our three-phase energy storage process within a tendon. And that is that there is a triple helix molecule that's even smaller inside the fibril. This triple helix molecule has a spring-like presentation that can actually stretch out and serve as an elastic energy storage device. These molecules will line up through crosslinks into the structure of a fibril, which you see here. These small little spring-like triple helix spirals make up the fibril, which has around it a proteoglycan fluff. It is a bungee cord-like material that allows these fibrils to slip past each other, making up the ability to have an elastic presentation again in simply stretching out these proteoglycan bungees. And lastly, when these fibrils come together to make the fascicle, the way they come together is unique in that they start to form waves in the fascicles. The fascicle is kinked, or what we refer to as crimped, and that is the third way that the body has the ability to store elasticity in the tendon to be able to be released back. These little red lines represent the actual echo structure. There is an epitenon that wraps around the fascicles, and that's what our ultrasound image is actually going to be bouncing off of, is that particular structure. Some of the higher end, higher frequency probes can get even more defined than that, but I use point of care ones that are courtside to my iPhone, and we're able to actually see the structures, but it is the fascicles that do that. Talking about tendons like springs and being amazed at this particular athlete here, what we're finding as they take a look at the different types of tendons is that there's special elasticity tendons, the Achilles and quadricep patellar tendons, just to name a few, can actually stretch between 12 to 15% of the fiber length. That's opposed to a posterior tibialis positional tendon, which is only able to stretch 1 to 3% of its length, and they're claiming that the reason for that is because those fibril bungees are particularly a longer stretch in the plyometric tendons that you're seeing this particular individual charge and then release those tendons as he's jumping. In the same article that's referenced down here, you will also read about the effects of aging and how, in fact, the cycle of loading and the tensile strength in tendons are particularly altered by that process. Rapidly, I'm going to call out the process as to how a tendon goes through its cycle of loading and where the process of pathology starts to occur. This is force. If you take a look here, a stress load, and on this electron microscope here, you can see the crimp that is present. That crimp is where we first start to pull a tendon into a stretch. We talked about before the proteoglycan bungees, and you can see that represented here. As the load starts to increase, those proteoglycan bungees start to get tight. And then lastly, we talked about that spiral effect of that molecule. And at the end of these three things, we start to reach a point where almost in my mind I hear creaking, because that's when the crosslinks start to get stressed and begin to break. We haven't had catastrophic failure yet, but they're at the end of the breaking, much like bottoming out on shock absorbers with too much weight in the back of your pickup. And then at the end of that loading, the molecule crosslinks start to fracture, and there's a progressive structural failure that will occur. This is really quite well presented by a group of insightful people from down under. Cook and Purdom about 10 years ago began to propose a model of continuum as to how a tendon goes through its breakdown process, whether the overload is from a mechanical stress on an initial impact and then recovery, or whether it's from overload rhythmically. It is worth your time looking into their work to evaluate how that progresses. And their real sentinel work indicates the continuum of pathology and how that physiology changes with recovery and what we can do to intervene. I'd be remiss if I didn't talk about the effect of simply a metabolic disease process on the stretchability of tendons and how likely tendons are to develop a tendinopathy. In the disease process of diabetes, hypercholesterolemia, gout, and obesity, all of these are background metabolic problems that predispose the tendon to a tear or to injury. However, it doesn't matter what the process is that brings a tendon to a injury state or a disease process. The recovery phases remain the same, and that is that there is an inflammatory phase in the first 3 to 5 days where there's infiltration of neovascularity into the fibers of tendons, because the tendons do not have natural vessels that go to them. And then along about day 3 to 3 weeks, there is a process of that filling in of those lesions with type 3 fibers that we talked about before, remembering that type 3 fibers are not linear. They don't echo bright, they echo dark because they absorb sound. And then lastly, a tendon goes through the process of converting those type 3 collagen fibers to a type 1 through a process of overload and injury. During that period of time, we can develop a tendon that is having a condition known as tendinosis. I want to spend a little bit of time now calling out specific imaging characteristics and specific diagnoses in that spectrum of tendinopathy. I'm going to start first with the most complex and go to the least complex. And obviously the first and most complex tendinopathy would be a complete tendon tear or rupture. Now, one would say that that's a catastrophic tendinopathy, but what I want you to realize is that in some of the research I did for this presentation, some sources say that 97% of all complete ruptures had a pre-history of a tendinopathy. And one of the proofs to that is that a very healthy tendon that has not had any type of injury to it can withstand loads up to 12 times the body weight. So there is only 3% of the time that catastrophic failures of a tendon rupture are as a result of genuine healthy tendons. When a tendon ruptures, it is truly impressive. If you've not had a chance to see it, I offer this particular video for you to review. Whoops, hold on one second. Coming back from that to this one. Clearly, if you've heard or experienced a catastrophic tendon failure, that's something that you won't easily forget. I'd like to have you take a look at the actual images from a tendon tear, at least of the heel cord tendon, because from that you can gain some information and insight as to what it would look like. This is an actual long axis image of the heel cord, and if you can look with me, this particular stub right here is the actual structure of the Achilles tendon. This is the tibia, the back, the periosteal echo from the tibia, and this is the flexor tendons of the Tom, Dick, and Harry muscles that move the ankle. One of the telltale signs that you've just imaged a catastrophic failure of a tendon in long axis is this little shadow right here that's called refractory shadowing. It is an artifact that will be very helpful in determining whether or not that tendon is fully ruptured. I'll play this for you. I had asked this patient to do plantar flexion and dorsiflexion, and you can literally see that that heel cord does not move where the flexor tendons of the ankle flexor and the toe flexors do. And down here, this is within a few days after the injury, you can see that neovascularity, the powered Doppler imaging of blood flow going into that peritoneum space where there is clear evidence of a catastrophic failure. Continuing on, after a complete tear, there's a partial tear. A partial tear images quite well as well. If you can take a look at this representation, this call out from the patellar tendon, you can see that the end periosteal echo of the patella, which is right here, has those fascicular striations, those long strand fibers over the top of a dark area. And if you can take a look at some of these fibers here that hang down into this anechoic or dark region, you can begin to say to yourself, oh, that dimension is a little bit larger than I would like, and there is darkness in there. But you don't get the full picture until you actually go to the cross the cross-sectional view, the short axis view, and you can literally see that there's a zone of retraction within that patellar tendon that represents a partial tear. Going down that toward the least catastrophic, we enter the area of a strain, which is basically where those microstructures begin to fracture, where we take it all the way down to where the mechanism of elasticity starts to get to the end of its travel, and we develop a strain process. If that goes into a vascular circulation and it becomes inflamed and we get blood flow going to it, we would then be able to call that a tendonitis. That is also what can happen as a metabolic process, where a person, like you would expect that jumper to be going up and down on a rhythmic basis and not giving those tendons, those tendon fibers, enough time to recover. If we don't have tendon fibers at fault, but in fact the tendon as a whole slides up and down within the sheath or the wrapping of the tendon, we can develop friction syndromes within the periphery of the tendon fibers, and those friction syndromes can set up inflammation on their own. Imaging, it would show up on power Doppler that only the periphery around those tendons would be active. And then the diagnosis of tendinosis. This is basically a process where there has been rhythmic irritation and then recovery and irritation and then recovery, and a tendon actually becomes quite large as it develops more fibrotic type 3 matrix. And what I'm going to show you here is that sometimes those tendons can become so thick and so broken down that they can actually have calcifications start to form in here. Orient with me, this is the actual humerus, this is the articular surface of the humerus, and this is actually the middle facet, but we're going to go from the middle facet or the infraspinatus to the superior facet on this view here, where you will see the cloudy-like structure within the tendon being calcification. Again, skin at the top, adipose layer, deltoid, and supraspinatus fibers going into its insertion point on the superior facet. And again, as we process medial to lateral, you can see that forming there. Now, in your mind, turn it 90 degrees. We'll go orthogonal to the short axis. This is the lesser tuberosity, and you'll actually see the coracoid process show up here. But you'll see us going through the calcifications, the hydroxyapatite deposition within the tendon, and you'll see us literally moving from superior to inferior, and you'll be able to also, and I'll do one more time through it, see the coracoacromial ligament start to form right here, and you can see how impingement of that particular tendon structure can go right underneath that bridge over the top of it. Lastly, as it relates to tendinopathy, I want to just briefly touch on a growing area of imaging. Utilizing elastography, we're able to now, in work-related musculoskeletal disorders or cumulative trauma, we're able to actually image the elasticity of a gummy formation that occurs in the fibers before it actually goes to full-blown tendonitis. And as such, we can screen employees for a pre-inflammatory event. But that's something we can talk about later. I do want to put some pearls of my history in scanning out for you to review. Remembering you can always go through some of these slides on YouTube following if we go too fast for you. But I will tell you that better than any of the videos I've watched, better than any of the webinars, is the time that I spent simply with an anatomy book open and putting gel on my child, paying them by the hour to watch Hogan's Heroes. And if you can just simply study anatomy, take a look at where the bone connects, they have amazing apps these days. If you can pull it out and move it in 3D and then get a willing person to let you put gel on them with a probe and move around taking a look at what's available for us to see. Once you do find that complex where you can regularly see a tendon, muscle, bone location, do your best to try to see if you can't memorize some landmarks that are around it. Now, there's excellent educational guides for this, but there's nothing like spending time literally looking at the echo texture of what you're looking at. If, for example, I guess if I should use an example of a landmark, on the back of your wrist there is something known as Lister's tubercle. It's a bony formation, kind of like out here the Space Needle would be, and you simply put the probe over the lower end of the radius, and you look for this incredible peak in the bony structure, and you know that right next to that is your extensor digitorum. It's that type of thing that really helps you to be able to put the probe down and start to get oriented to a tendon. So number one, own the anatomy. Number two, try to memorize landmarks. I don't know how many of those that are watching fully understand the concept of anisotropy. If there are many of my physical therapy colleagues there, I want to try to spend a little bit of time going through that with you. The sonographers that are out there will already understand it. But in essence, anisotropy is where your transmitter of your signal goes out. You want it to strike a structure and come back so that your receiver has the ability to determine that there is a structure there. If you move your probe at an angle to where it sends out the signal and it ricochets away and does not return to your probe, we have darkness. What I'd like to show you here is an example of using anisotropy, which to me is the easiest way to follow a tendon. I'm going to be cutting across the long head of the biceps tendon, and I'm going to be taking it from the top of the humerus, and I'm going to be moving it down to where it actually goes under the pectoralis major tendon. So here we are. Here's the long head. I'm wagging the probe, making that signal go down and then come back, and I'm attempting to keep the fibers in short axis in view all the way down to where we get a little bit of a hypoechoic return of muscle fiber right here, and you can literally see the pectoralis major tendon going across the top of it. I'm going to do that again for you, and I want to talk you through how the cross-sectional area of the long head of the bicep is staying in view by toggling the probe to keep the echo texture clear as it goes through that bicipital groove and then down to where it ends right here. The same thing is true as we take a look at the way we view it in long axis. And if you can take a look at the periosteal echo here, you'll notice that that is the pectoral tendon here. And as I move the probe up and down, trying to keep these fibers perpendicular to the sound waves, the actual fibrillar structure of the long head of the biceps is evident right here. And again, starting at the bottom, this is the biceps tendon, the actual muscle there. This is the tendon of the pectoralis in short axis. This is the mid long head of the biceps tendon as it goes through the peaks of the bicipital groove and continuing on. There are so many wonderful YouTube videos on anisotropy that would help you understand that, but I say use it, but recognize that it has evidence of artifact. Making this so that I don't rush my partner too much, I'm going to just go through the fact that for me, doing a short axis scan is the best way to take a look at hypoechoic zones. Taking a look at a tendon in long axis is the best way for me to be able to take a look and see integrity for tears. Remembering that tendons actually can move and we can watch them move, so load the tendon to improve some of that echoing. And then finally, if you're over something that looks like it is the problem, push down on it. We call it sonopalpation, but press down on it. And if the person says, yes, that's exactly where the problem is, then you know you're right on top of the problem as opposed to not. I'm going to just quickly go through this. This is a template that I like that organizes the way you scan things. And once you find something, being able to do some comparison to interpret the pathology, always remembering that it is better to scan in 2 planes. I do want to provide this next series of images to you to try to reinforce the importance of 2 planes to get a good read on your pathology. is Prince William here attempting to give a gesture to the paparazzis over here, or is he in fact ordering 3 pizzas for Buckingham Palace? Anyway, that was kind of a funny. Comparing one side to the other side is not always the right thing to do, but most of the time we'd like to think that it is a positive normal on the contralateral side. And then I'll make sure this goes fast. These are just some genuine dimensions for measurements. And as it relates to relevance, I want to pass it over to my colleague in Arizona, who hopefully can deliver it with at least a little less speed and a little more timeliness as that I have. And thank you for your time as I now give it to my buddy Colin.
All right. All right. Thank you, Greg. That was awesome. Very well done and very impressive. I'll be quick with the introduction, and I apologize in advance. I like to go really fast because this is I like to talk fast because this is a passionate topic of mine. And we can have the questions at the end. I'm a physical therapist. I work as a physician extender in a very unique role that I don't think there are many therapists in the country who get to experience. I practice doing musculoskeletal ultrasound diagnostics on a full-time basis, and I consult and am employed with numerous clinics here in the valley of Mesa, Arizona, Phoenix, Arizona, Tempe, Chandler, Queen Creek, and Gilbert. So I've compiled some case studies here. These are all authentic. These are all images that I've done personally, and I wanted them to come across as something that wasn't cherry-picked. Things you can find. They're, as Greg said, you need to own this. Take these initial cases and use it as to fuel your curiosity, if you will, and go out and learn more. So here's some examples. Starting with some imaging facts and locations. Ultrasound is the most sensitive tool in imaging tendinopathy, especially if we're comparing it to MRIs. And the tendon that I broke down here, and according to the reference on the bottom, particularly more susceptible to tendinosis for whatever reason, the rotator cuff tendons, specifically the supraspinatus and infraspinatus, and the biceps long head and the proximal aspect of it, the Achilles tendon, the common extensor tendon of the elbow, the first dorsal compartment of the wrist, abductor pollicis longus and extensor pollicis brevis, and the biceps brachialis insertion to the radial tuberosity, as well as the posterior tibialis. So some secondary signs, some findings, and these are with respect to musculoskeletal ultrasound imaging. Some secondary signs you will see are tendon calcifications, tendon sheath effusions, bursitis, and cortical erosion or hyperostosis at the insertional areas, otherwise known as enthesophytes. I find it helpful to grade the level of tendinosis. I work in a pretty high volume, fast paced atmosphere where the physicians or provider, we want to get to the bottom line of this quickly. What's the level? What are we dealing with? What's mild, moderate, or severe? I have some examples of those, but then this reference at the bottom, this Griffith reference, which you'll find that I've used for a lot of these slides, this is a pretty heavy, and it did a very good, it's a heavy reference, and it does a very good job of kind of breaking this down. And again, mild, moderate, severe, there's a high level of subjectivity with it. I like to use it because I'm confident with the number of scans I've done. I'm studying for this webinar. I've tracked about 7,500 cases I've done personally since 2013. And that's just what I could find on my hard drive. So once you've done that many cases, it becomes easier to grade. So repetition is helpful. We like to routinely examine with color Doppler imaging. What you'll find with very long-term chronic tendinopathies are you'll see some neovascularity infiltrating the mid-substance of the tendon. And in your more acute cases, you'll see Doppler kind of active on the periphery of the tendon. And be careful about using the contralateral side as a normal reference. Subclinical tendinosis is common. Some terminologies, and Greg's already done a wonderful job at kind of going through a lot of this. Just some findings in terminology we use in the diagnosis, in the assessment, is increased tendon thickening, increased hypoechogenicity, and progressive loss of fibrillar pattern. Positive findings, as I said before, are often located in the asymptomatic patient. Just for reference, and this is just to file it away, we find focal calcifications in about 21% of normal asymptomatic subjects, as well as fluid in the retrocalcaneal bursa in 35% of normal subjects, and irregular calcaneal bony contour in 63% of normal subjects. And these are just 3 examples. I just wanted to get that across, because sometimes what you'll find is you're doing one side and then you say, well, let me look at the other side just for reference sake, and you'll find that that side has tendinopathic findings as well. So just keep that in mind. So here's an example. We'll get into the images. I started with the shoulder. So the first slides are going to be of the shoulder and the biceps long head. What we have here is a biceps tendon and long axis. So to orient you, here's the proximal aspect of the humerus. Left is proximal, distal is to the right. We have a poorly recognizable fibrillar pattern here. You'll see this heterogeneous border on the superficial border here, how it kind of comes up and lumps over. We have this would constitute some of our tendon thickening, as well as the loss of fibrillar pattern. So as you can see, you see the streaks here. We should see more of what looks like this throughout the tendon. We don't really see much of that here. There's some really dark fibers on the top, some diverging fibers here, indicating possibly there's some kind of split tear, but we wouldn't know that unless we looked in the short axis view. Remember, one view is no view. Whatever you find in one view, you should be able to find in the other to call it an assessment. This is actually the same patient in the short axis view. Okay, so we go back to that long view. Remember how I said we see these kind of diverging fibers here. Well, turns out here is part of the bicep tendon, and here is the other part of it. So, and this is our our bicipital groove. So we're looking at this tendon now in short axis, the bicep. This is the greater tuberosity, and up here is the lesser tuberosity. And centrally located is the bicep, and we have this kind of split tear of the tendon. This is often pathognomonic with upper border subscapularis tears, because remember how the subscapularis inserts to the lesser tuberosity. It has a rather large attachment. So these findings, when you see this finding, make sure you investigate the subscapularis closely. I'm unsure as to this particular patient if they did. It is not clear to me on this image alone if they did or not, and I can't recall that particular case. But for the biceps, we can speak to this split tear. Here we have the rotator cuff. So to the right is distal, left is proximal, and this is the bony contour of the humerus. I want to point out to you, and Greg did a good job of his. I'm going to get a little more specific. Basically, when you're looking, not all, but most tendon insertions have what's called, I call it a parrot's beak appearance. So if you look at the insertion here, how it kind of comes to a parrot's beak, and we have this hook on the bone. So from basically from here to here is what we call the footprint of the tendon bone interface, and from this aspect of the cursor proximally, this comes up into the ball of the humeral head. This is what we call, or what is, the articular margin. So the hyaline cartilage covered. There's no functional attachment site there. We're the main investigation region. We're looking at for these supraspinatus tears or rotator cuff tears on the humerus are in this zone here. This is a case of what I would call more on the mild side of tendinosis. This patient presented clinically with gross impingement syndromes, no frank loss of strength, but they had, pain in end-range flexion, abduction, and external rotation without significant loss of range of motion and no distinct capsular restrictions. Note the early mid-substance changes. So note the changes to the tissue. See on the darker edge, this is dark edge here on the edge of the, at the proximal end of the footprint. We have this, as well as some streaking and clefting in the mid-substance. This brighter spot up here, we might be, as Greg mentioned, the facets of the greater tuberosity. This might be actually some infraspinatus coming over, because remember the infraspinatus inserts to the middle and distal facets of the greater tuberosity. Actually, there is some overlap if you're aware in your scanning, or if you don't scan, but it is good to be aware of that this can overlap and you can catch some of this on the top. And this darker line here would be some distension of the subdeltoid bursa, and the subdeltoid, the peribursal fat layer, just superficial to it. And over the top here is the deltoid, and that the most superficial layer is skin. Just so for reference sake, from top to bottom is superficial to deep. Another rotator cuff. This is a supraspinatus. This is a more moderate to severe case. Again, so we're going to see some similar features. I try to pick images with kind of a theme going, where we can, based on, so here's our articular margin of the humerus. From this aspect of my cursor to this aspect of my cursor is the tendon footprint. Now, what I wanted to make you aware of, when you start to see these breaks in the cortical outline, this is more consistent with some moderate to severe cases, and possibly partial tearing. Okay, now to confirm if there's a tear that's retracting, or if you have some paradoxic movement in the tendon, you're gonna use your dynamic maneuvers. We're gonna move the elbow into abduction and maybe do some resisted testing under the probe. In this case, note how the tendon keeps its volume. This was not a case where there was a massive high-grade tear. This was just a chronic tendinopathy. Notice how the tendon keeps its volume, but yet we have these features. So we have the clefting at the tendon bone interface. We have this distended layer between the tendon and the peribursal fat line of the subdeltoid. This is indicative of a moderate to severe tendinopathy. Again, another case, similar. Okay, they look like similar pictures, don't they? So when you do a lot of these, you're going to start to see these characteristics again and again, and you'll get them drilled home. But the key is repetition. So again, at this proximal footprint, note how we have this break in the bony cortex, and adjacent to this break in the cortex, you'll see how you have your darkest layer of the tendon. This signifies tendinosis. This signifies loss of fibrillar pattern. There's some fluid in this region, which dark on ultrasound signifies that there is some effusion, as we see as well in the bursa. Okay, and then this is a very thickened bursa on the peribursal fat line as well at the subdeltoid. Okay, so here's another case. This is a supraspinatus tendon in short axis. In this view, we're looking at the rotator cuff interval. This tendon here is the biceps tendon in short axis, and just deep in to the left of it is the subscapularis. This bright white line is the cortical outline of the humerus, and the arrow is pointing to this divot in the tendon at the bursal layer. I hope you all can make this out. We actually had an MRI on this patient. Language was more vague than the ultrasound, but it was confirmation that we were correct in our assessment. This is just one example of a low grade tear of the supraspinatus at the bursal layer. Okay, and then as well as you can see this bursal line distinctly separated from the tendon as it comes over. I call this the wagon wheel view. I use a lot of analogies in my, I like to think that I'm fairly simple-minded when it comes to this. There's no need to overcomplicate it. I like the wagon wheel view. So typically, what you look for is outlines, just like when you're looking at X-rays, you're looking at your outlines and how shapes should look. So you have the cortical outline of the humerus in the short axis view, and then the volume aspect of the tendon. This should be fairly symmetrical with it. Now, when you look at this view, what does not look right to you? You see this swelling in the bursa right in this layer. You see this bump up there, and then corresponding to that, you see this divot in the tendon here. This signifies some bursal-sided fraying of the rotator cuff, likely from compressive impingement against the roof, the coracoacromial ligament. Again, rotator cuff tendinosis is supraspinatus. So this is a view I want you to look at. We have some flattening or loss of volume of the tendon. So, and I mentioned that earlier. So you have your parrot's beak appearance here. We're in long axis. Again, the footprint from roughly here to here. And again, every patient is different. No two tears are the same. No two rotator cuff footprints are going to look the same. These are all things that come with repetition. So you see how this is kind of a flatter rotator cuff footprint in general. What makes this so special or different? It's not. It's just I want to point it out to that these cases are all different. We have what is obvious, what doesn't belong in this picture. Tendons should normally be brighter, more echogenic, hyperechoic. We have this hypoechoic signal coming from the footprint, this area of the tendon adjacent to the footprint right here where my cursor is. Contrast that with these fibers, just proximal and superficial to it, and correspond that to the patient's signs and symptoms of what they're presenting with. And the ultrasound examination is very consistent with tendinopathy. But in this case, the loss of volume. So we have this flatter. You can look at it again. Kind of my point earlier of you're looking at the bone. The tendon and bursal lines should be fairly consistent with it. If you were going to draw lines, see how it kind of draws to a more acute angle as it gets to the distal side. That's a signal that there's some attenuation of the tendon, loss of tendon volume. Why is that? It's likely that they're starting to develop a larger tear in this region. This would not constitute a high-grade tear yet, so it falls under the classification of tendinopathy. Rotator cuff again. So from this view, this is the long axis. Again, left is proximal, right is distal, and you see that this is kind of a more moderate to severe side. You see the the tendon, and again, look adjacent to the rotator cuff footprint. This is an articular sided formation where this dark signal adjacent to the irregular footprint, you're starting to see a pattern here. Okay, this is why I lined these up the way I did. I wanted you to see kind of what is consistent with these patients. And again, we have our bursal, kind of the superficial layer of the tendon where my cursor is moving here. Superficial to it, we have some bursal distension and the brighter peribursal fat line of the subdeltoid. This disorganization at the tissue here. Again, this is what I would, it becomes a semantics game at some point. I have to adapt my language to which physicians I'm working with. Orthopedic surgeons like to talk in high grade versus low grade, meaning what's surgery, what's not. Sports medicine, non-surgical physicians like a little more detail. I just have to kind of be able to adapt it who I'm working with in terms of what we're calling this. But at the end of the day, this is a tendon that likely does not need surgery, that can be rehabbed and maybe be a candidate for some other interventions, which can maybe be covered in another session some other time if there's interest. But these are all interesting cases in the sense that these consistencies of these moderate to severe tendinosis we see there's a poor kind of outline at points on the rotator cuff footprint at the tendon bone interface. And again, not to sound like a broken record, how adjacent to these cortical findings, we often find the signal we're looking for with tendinopathies or small tears. And again, short axis view. Okay, this is our wagon wheel view. All right, so cortical bone at the bottom. Whoops, cortical bone at the bottom. Just superficial to it. This is actually the bicep tendon here. Not a clear picture of it, but this was in the supraspinatus tendon to the right of it. A lot of clefting, a lot of disorganization at the free zone, just lateral to the bicep. And again, our bursal, there's some bursal distension adjacent to it, to a thickened peribursal fat line of the subdeltoid. So the signal in the tendinopathy we're looking for in this picture is this finding. This is a large surface area finding in short axis or cross section of the supraspinatus tendon. Supraspinatus and long axis now. So again, this is probably an example of a rotator cuff that is closer to a surgical candidate than the previous ones we showed. What makes me say that? Well, I want to point out that see just the level of disorganization that's in this tendon. Okay, there's barely any recognizable fibrillar patterns, meaning normally these tendons are nice, and as Greg pointed out, they're nice and dense fiber packed through here, all linear in nature, just stacked on top of each other, where we don't see that here. Look at our articular margin, okay, and then the footprint. This area right at the footprint here, this dark spot, there's a large void or signal, and then in the mid substance above it, same thing. We see some clefting and streaking, and then as well as this bursal line, where basically I want you to understand that the tendon basically ends right where my cursor is, and from the cursor to the peribursal line at the deltoid, just deep to the deltoid, this is all bursa. Notice how it comes over the top. The tendon does not come over the top here, so don't get fooled. The tendon ends right here. This is the tendon. If you can all follow my cursor, and I'll take questions at the end. I know that this is, if I'm going fast, just write these down as we're going, because this is key to understand. Early in my career in scanning, I got fooled a lot. I thought this whole thing was a tendon. I'm like, oh my gosh, this looks weird. I don't know what I'm looking at. And diagnoses became, they were incorrect and all over the place. And over the years, when and the repetitions came, I worked with I had some very high level mentors and got to observe a lot of surgeries of my work. It was valuable feedback for what I was looking at in the clinic. So this is a very, this is more definitely on the severe side of tendinosis. There's some articular sided, I would call this articular sided fraying. Don't know if there's any frank retraction on this patient or not. But I want you to note, and again, where we talked about the flattened appearance, how all this should correlate. Remember these lines of symmetry. For the beginner, these are important to understand how basically these lines should be symmetrical in terms of you're looking at the cortical line versus the bursal line. Okay, and for the non-rotator, the most common sites we're going to look at is the Achilles, patellar tendon, posterior tibialis, common extensor tendon, the gluteus minimus and medius, as well as the hamstring, the proximal attachments of the hamstring. Okay, so here's an insertional Achilles tendon where we have some power Doppler signal at the mid-substance. This signifies a chronic, more on the severe side of tendinosis, and we have note as well down here. The retrocalcaneal bursa, to the right is distal, to the left is proximal. Some corresponding signs as well of there's some loss of cortical outline at the distal end. A short axis view of the same patient where you look at the peritendon outline. This is thickening of the peritendon sheath and these intrasubstance clefts. Okay, and I want you to also note this signal kind of reverberating down beneath. We're getting, this is called a increased through transmission. Why is that? It's because the sound is traveling through this tendon more densely than it should. There's a lot of, these voids in the tendon allow the sound waves to travel through it quicker, giving us this signal. So this is a good secondary sign of kind of confirming what we think in this patient. Again, short axis where I just kind of made this caliper as a reference for the doctor signing off on the exam. This is a pretty severe case of tendinosis, and again, as Greg mentioned, we want to see those cross sections. This kind of gives you a good view or a good kind of snapshot into that layer. And note the halo around it. There's a lot of peritendon thickening, and again, we have these secondary increased through transmission deep to it, letting us know that there is some voids in the tendon, the sound waves are getting through. Patellar tendinosis. So this is the inferior pole of the patella. We see these irregular cortical outlines, streaks in the tendon. So to the right is distal, and the tibia is down here. We see this thickening. See how the tendon comes and kind of forms a thickening at the interface with the inferior pole. Secondary signs of bony irregularities at the tendon bone attachment, where this was a high-level weightlifter who spends a lot of time in deep knee flexion, squats, and that sort of thing. Trained through this for too long, and this is how they ended up. Hypoechoic clefts and streaks in the middle. This all adds up to a tendinopathic appearance. The same patient with a Doppler, no Doppler findings on this. This is a very chronic patient. Oftentimes, if it's very chronic, you won't find any signal coming in through there. And again, a short axis view of that patient, how this calcification or entheses, synthesophyte, this whole thing is the tendon, but you see how this is eating into it. It becomes a rope over a rock where that tendon over time starts to kind of get frayed on this calcification. This is a posterior tibialis tendon at the navicular insertion, and I realize we're getting crunched on time. Okay, so again, this is we're looking at these clefts at the navicular, and this is a very severe case. So, short axis view of a similar patient, okay, where we have the short axis case, and the halo around it, and we note these clefts in the middle, signifying thickening and hypoechoic clefting and loss of fibrillar pattern. A common extensor tendon of the elbow. Proximal is to the left, distal is to the right, and we have some undersurface fraying and clefting. This would probably be consistent with on the severe side of tendinosis. Not probably, it is consistent with severe tendinosis. Okay, a similar picture where you're starting to see my language and my what we're looking at. The cursor is going over spots where we're looking for tendinopathies or irregular portions of tendon where it should be bright. It should look more of this texture. Again, in the middle here, large void, as well as the irregular bony landscape here. To the left is proximal, to the right is distal. This is a gluteus medius and long axis. To the right is distal, to the left is proximal. This is a thickened trochanteric line. There's a dark area of distension mildly located above it, and below it, here's our parrot's beak, where we have some decrease in fibrillar patterns where the cursor is moving. No irregular bony cortex. This is probably more of a mild to moderate, more on the mild side of tendinosis and of the gluteal medius. This is more of a larger tear of the gluteus medius. As we see this, the distal footprint, there's this signal off the side, and we have the flattened appearance of the tendon. Compare it to this, where it keeps its volume, where there's really nothing here. We have some retraction back to proximally here. So hang in, guys. I got a couple more slides left and we're about done, and we can take some questions. This is a short axis view of the gluteus medius. We see this thickening, hypoechoic clefting adjacent to this irregular bony cortex. Now that could have been a little better done on the imaging part, but that was part of the reason why I picked these images. These are authentic, and these are oftentimes you don't have the chance to cherry pick. This is a focal tear of the gluteus medius. Note the break in the cortex break and the signals that are adjacent to it. And again, this is the gluteus minimus and long axis. This is the gluteus minimus tear at the insertion. Note the break in the cortex, and then this is actually some retraction back proximally. Okay, so right is distal, left is proximal, and we have some bursal effusion over the top. And again, this is a short axis picture of the same patients. Okay, and this confirms our suspicion that there is a large tear at the anterior trochanteric facet. We have these clefts here where this is actually moved a little bit retracted proximally. So there are clefts in the middle. The footprint tear is located right here. And the last few slides, we're looking at a short axis ischial attachment of the conjoint tendon and the semimembranosus. Both are involved, as we see on the ischial attachment site, but look at the contrast. Which one is more involved? Is definitely the semimembranosus compared to the conjoint tendon. We have more, it's just easy to compare and look at the amount of clefting that's in this, the peritendon thickening around it compared to the conjoint tendon. And again, long axis view, this is the same patient. This is a middle-aged distance runner, a pretty high-level distance runner, where we have the semimembranosus and long axis. Left is proximal, right is distal. All this streaking and clefting we have through the middle. See how the tendon is very thickened, poorly defined outlines, as well as the cortical edges. The hypoechoic clefting is streaking in the middle. And the conjoint tendon of the same patient looks very similar in long axis to the semimembranosus, but slightly less involved, as noted with the short view, how we have, you know, there is some tendon thickening, though not as quite as severe. This cortical edges and outline is definitely a signal that tells us that this bone has been irregularly tractioning on its attachment site for a long period of time. Okay, so we can field some questions if people are still tuned in. I appreciate your time.
Colin, I jammed you, buddy. I'm sorry.
Greg, that's not a problem. I just looked down and it was time.
What I'm going to do is I'm going to read a couple of the questions that I have for you to catch your breath, Colin.
Yeah.
And I think that may be relevant. I'm going to go ahead and read both of them. One of the questions is, do pediatric tendons have different characteristics from adults? I'll have to tell you that I would say that the pediatric tendon might have, if anything, just a little bit thicker distances between the echoic lines or the fascicular lines. I do find that as an adult or as an athlete is more active, it seems as though we actually have thinner dimensions to the tendon. I think that's borne out in research as well, and I think that a pediatric tendon may be thicker in certain places, and certainly would echo reflect or give us an echo signature a little bit different, but not of significance enough to be of any consequence. The second question is, do ligaments have the same structure as tendons? Microscopically, they really do, meaning that they have type 1 collagen fibers. But if we take a look at the way a ligament literally looks when you're scanning it, a ligament will take more of a band or a sheet as it goes from one location to the other, and a tendon will have a cross-sectional area that's more oval or more round. The exceptions to that are tendons like the ligaments like the lateral collateral ligament. But most of the time when we're looking at ATFLs, when we're looking at any of the other ligaments, they have more of a band structure to it. Over to you, Colin. Do you have your questions yet?
Yes, I'm just kind of getting into it here. Having a little difficult time reading it. The first one I see is, there any relationship of the shape/slope of the footprints along the tuberosity and possible likelihood of tendon pathology? Is there any relationship of the shape slide a little bit? Yes, those are points I was trying to make with the outlines and the symmetries we were looking at. So, but also, this is also a case, this is a good question, by the way. This is also a case of, if that's something that's in question, if you're like, well, that particular footprint does not look normal, then compare it to the other side. If you're just comparing footprints, then that's a very good reason to go look at the uninvolved side. I don't know if it predisposes that particular footprint to pathology or not. But if you're questioning, is that normal, then just look on their other side. The second question is, cortical bony irregularity under a tendon more specific for a partial tear or tendinosis? I've heard lectures that say both in the past. Again, that's a nice question. I would say it depends. It's one of those things where it's a matter of semantics. So you want to be able to differentiate what's a low grade versus high grade tear, meaning low grade is more consistent with tendinosis and is non-retracted, whereas high grade is you have those features of irregular bone, but there's some tendon retraction beginning to occur. Maybe dynamically we see some fibers that are moving paradoxically, whereas they don't move with the bone. If the tendon is attached to the bone, tendon is going to slide with the bone during movement if it's intact or not. That's one way to differentiate. Again, you have to put the caveat, yep, there's a partial tear, but this is consistent with tendinosis, or there's a partial tear that's high grade in nature. And maybe in some cases, and Greg, you can speak to this, is an MRI warranted if there's any question? And then could it be normal? Could it be normal a tendon that is flattened with no loss of the fibrillar pattern? Absolutely. And if that's a question that you have, then look at the other side, because oftentimes it'll be similar. If there's a normal tendon that's just flattened, then that's the way they are. Or that's the way that particular individual is made. And I apologize, I'm trying to go fast, and I apologize. I hope I'm answering everybody's question. Greg, do you have any more questions? I just got one more on here that came up. Do you have any more that you wanted to answer?
I don't have any more that have popped up for me, and really exciting to see how many people are hanging in there on this particular subject. I know this is a pretty important subject to us right now, and not just ultrasound imaging, but tendinopathy as well.
Well, yeah, absolutely. We can do this for hours. The next question I got is aside from its low cost, why would you recommend ultrasound over MRI in the diagnosis of tendinopathy, thinking that ultrasound results is also dependent on the skills of the operator? Again, very good question. Ultrasound is operator dependent. It's only as good as the person who's using it. In the hands of a reliable operator and a skilled operator, it's a no-brainer to go with an ultrasound over an MRI for sensitivity, specificity, and resolution.
Absolutely, and you can load the sucker and see things move that would never show up.
Absolutely, yep. But if you live in a region where you don't have access to a reliable sonographer, then that would put you in a situation where you're asking your question of well, what test do I order? Next question here. And as an ultrasound tech, we often see patients with increased pain and problems post a series of dynamic PT treatment to evaluate for tear versus tendonitis, tendinopathy, which now has led to the ultrasound. Possible steroid injection, often injection or calculus lavage. Since you are both utilizing ultrasound in your office, has this changed your approach or treatment plans? That is to say, since you are able to evaluate the level of inflammation, how did this alter treatment? Not including surgery, of course. I am currently a massage therapist in training, and I'm curious to know. Greg, do you want to take that one?
I missed the very first part because they got pretty specific about lavage and all that, which is seemed like.
Well, what I'm getting out of it, to evaluate for tear versus tendinopathy, which now has led to the ultrasound, possible steroid injection, since you are both using it.
Yeah, I would have to say that for me, it has a lot to do with how much of the cross-sectional area is still intact. I think that if I can see viable tendons and it looks as though it gives me enough of a cross-sectional area to work with, I have no problem proceeding forward with conservative intervention. However, I look at the tendon and I see that it's 75% torn. I see the dynamics of it. I evaluate the patient. That's just as we look at structure at the tendon. There are times when a patient presents with symptoms at the shoulder, and we can screen with ultrasound and find out that all of the structures are intact at the shoulder, and in fact the tendonitis that's there is coming from neural pathology. It's profoundly important that I don't spend forever working on the shoulder when it's not a shoulder problem. So to me, to be able to critically discern what is the actual problem has probably saved 3/4 of my patients from going to MRIs.
Yeah. Yeah, and then part of that question was regarding intervention, and I know that was something you and I talked about. We wanted to kind of leave out of this, and I mean that's an awesome question. I think that might even be a topic for another webinar if given the opportunity.
Right, monitoring progress, seeing what it is that you're doing, what do you look at to see if you're improving things, and how to treat it. You're right, Colin.
There should be one last question.
One last question from Matt. A lot of times I get pushback from my colleagues about doing MSK ultrasound, but specifically for things like tendonitis, since it likely won't change my management. Unless there's suspicion for a complete tear, I have a hard time convincing my colleagues to invest in ultrasound. Any thoughts? I got a lot of thoughts. That's an awesome question. And again, this could, I don't want this to take us into a rabbit hole, but my job in the field is extremely unique, where I work adjacent to physicians and surgeons, and I get orders specifically with very specific reasoning. From a therapist standpoint, maybe Greg, you be better.
Yeah, I'll say to him as it relates to me, it judges whether or not my intervention is successful. As I see the fibers becoming less hypoechoic as they return to the same level of echo texture as the contralateral side, I know I'm on the right track. If you believe in iontophoresis or if you don't, when you do iontophoresis and you see a follow-up reduction in fluid there, it's very hard to say we're not making improvement. As you use the Aussie technique for tendonitis, seeing those fibers actually become more and more clearly defined gives me the confidence in saying I'm in the right track. I hope that answers your question some.
Yeah, I mean, that's a great question. And then that could also take us into, well, as therapists, how can we start utilizing this in everyday practice and start, being compensated for it? How do we move it into the business model side of things? And to me, that question goes hand in hand with that conversation. So maybe in the future we can talk more about that.
Sounds good.
Okay, well, thank you very much for that amazing presentation. Unfortunately, we're gonna have to call it a night. Thank you everyone for hanging in there with us, and on behalf of the AIUM and the APTA, thank you for participating, and remember to complete the post-test and the activity evaluation. We hope you enjoyed this presentation as much as we did, and we hope to see you for future webinars. So good night, everyone.